So let's talk a little bit about allergic rhinitis, all right? Allergic rhinitis can be seasonal, perennial, and you can have perennial with seasonal exacerbation. So there's all sorts of allergic rhinitis, right? And some of it also depends on where you live. I come from California, where we have beautiful sunny weather, so things pollinate year-round, which is different than other parts of the country where they have snow, so things don't pollinate year-round. So sometimes your seasonal allergies can be year-round. So it, again, depends on where you're living. There's vasomotor or non-allergic rhinitis and rhinitis medicamentosa, and we'll talk about all of these. All right, seasonal allergies are usually due to things that have a season: grasses, trees, and weeds, pollens. All right, perennial or year-round allergies are things that don't have a season: dust mite, indoor molds, and animal dander. All right, so there are 4 major symptoms of rhinitis: nasal congestion, rhinorrhea, sneezing, and nasal pruritus. Those are the 4 sort of cardinal symptoms of rhinitis. Allergic rhinitis, as its name implies, is IgE mediated. There is some IgE mediated sensitivity. Right? Nasal smear can show eosinophilia, though no one I know does this other than study situations. But study situations are similar to test situations, right? All right, so what might you see on physical exam? Nasal mucosa will be swollen and pale. Pale, boggy turbinates is what you'll see. Cobblestoning of the posterior oropharynx because of that postnasal drip causes an irritation. So you get what's called cobblestoning of the posterior oropharynx when you look in the back of the throat. All right. Nasal polyps are not common in children. All right. In adults, we see it a lot more, but if you see nasal polyps, you should start thinking of things like cystic fibrosis, but keep in mind, not every person, every child with nasal polyps has cystic fibrosis either, so you may have some nasal polyps as well too, but that should at least start the ball rolling. All right. How do you treat allergic rhinitis? Avoidance, medications, and allergy shots. So the first thing is avoidance. So we want to test patients to figure out what they're allergic to so you can give the appropriate advice on what to avoid, right? Blanketly avoiding things doesn't always help, so knowing what they're allergic to can help you to tailor that advice, right? Antihistamines are most commonly used, but keep in mind that antihistamines don't help with nasal congestion. And I mentioned the hallmark feature, congestion, rhinorrhea, itching, and sneezing. Antihistamines will only help with 3 of those 4 symptoms. You really need intranasal corticosteroids to help with the congestion. All right. And then what I do specifically is offer allergen-specific immunotherapy, allergy shots to hopefully desensitize these patients. So that's something that's different that can be offered by an allergist, right? So first thing, again, like I said, is avoidance. Avoid the things that you're allergic to. So you do a skin test or blood immunocap testing, as it's really called, even though everybody calls it RAST testing. It's not RAST testing anymore. No lab does that. RAST has to do with radioalloabsorbent testing versus immunocap is immunofluorescence testing. It has to do with the way that it's looked at in the microscope. The common vernacular has been RAST test, but please keep in mind that it's not done that way anymore. All right. So things that you can advise, all right? Pollen allergies, depends on what they're allergic to. So trees pollinate in the spring, summertime is grasses, fall is weeds, all right? So if you know what they're allergic to, you know what time of year that they may have a problem, all right? Keeping windows closed, having a HEPA air filter, showering if you've been outside, these may all be helpful things, right? We don't want patients to be limited in what they can do, right? Should they not go outside and play sports, or should they? No, I don't believe in limiting children. My job is to better control you and give you advice so that you can go and do all the things that you need to do, right? Dust mite allergies. Dust mite covers, encasings for your mattresses and pillows can be super helpful. Decreasing the humidity. Dust mites love to grow in higher humidity. All right, washing your sheets weekly in hot water can get rid of the dust mites as well too. So again, if you know what the patient is allergic to, you can tailor that advice, right? Blanketing, telling someone to get dust mite covers if they're not allergic to dust mites isn't going to help them, right? HEPA air filters can be expensive. So is it something that's going to help them? HEPA air filters filter out smaller particles, things that are lighter, like pollens, not heavier things necessarily like pet dander or dust mites all the time. All right. Pet allergies. No one gets rid of their pets. They will get rid of me before they get rid of their pets, right? No one is going to get rid of their pet. But if you find out that they are allergic to the pet, maybe you can get them to keep it outdoors or at least keep it outside of the bedroom, right? I tell patients, create at least an allergy-free zone in your bedroom. Maybe have a HEPA air filter in there, keep your bedroom door closed, keep the pet outside, so that 8 or 10 hours a day that you're sleeping in your bedroom, you're in your allergy-free zone, right? Sometimes that's the best we can do. Interesting thing, keep in mind that if you remove a cat from a household, it takes 4 months for that level of cat dander to go down to be equivalent to the level of a home that doesn't have a cat. 4 months is a long time. Cat dander is very sticky. It's also very ubiquitous. So, they may come back a week later. Well, doctor, I got rid of my cat and I'm not any better. I should just bring it back. No, tell them that it's going to take a while, right? All right. Treatment, antihistamines are again commonly used, but keep in mind that I did say they don't help with nasal congestion. You do need an intranasal corticosteroid for that. Amongst your antihistamines, you probably know that there are the early first-generation antihistamines, things like diphenhydramine, chlorpheniramine, and hydroxyzine that cross the blood-brain barrier. All right. They can cause sedation, blurry vision, dry mouth, lots of studies that show that people might have a hangover effect the next day, right? So I'm really super careful about not giving Benadryl unless it's needed. We have a lot of other choices nowadays that we don't need to use Benadryl for chronic conditions like allergic rhinitis, all right? Second-generation antihistamines are less likely to cross the blood-brain barrier, so they don't cause sedation, right? So you have things like cetirizine, fexofenadine, loratadine, desloratadine. They cause little to no sedation. All right. Allergen immunotherapy, or allergy shots as it's called, works well for IgE-mediated conditions. All right, so again, we need to know that they have some sensitivity for me to be able to desensitize them to something. All right, what we're basically doing is giving increasing doses of the allergen in a very specific way, subcutaneously. What I'm trying to do is decrease their IgE production to that antigen, all right? We're increasing T regulatory cells, increasing things like IgG4, your blocking antibody. So you're making an immune change in these patients, and that's why it's effective. The medications help to temporarily alleviate their symptoms, right? But they're not doing anything for the underlying pathogenesis of the disease. And this is something that allergen immunotherapy can do. It's disease modifying. Vasomotor or non-allergic rhinitis. Many patients come to me because it's thought that they have allergic rhinitis, and you test them and they actually aren't allergic to anything, right? And this is probably why antihistamines were not helpful to them, because their problem is not histamine mediated. All right, we think these patients have reaction to vagal stimuli, neurogenic stimuli. So you'll often see similar symptoms, all right, sneezing attacks followed by nasal congestion. It can be with exposure to cold, sunlight, spicy foods, smells, different things. So skier's nose is an example. With exposure to cold, their nose will just start to water and drip. Gustatory rhinitis can happen with food, right? Which can be embarrassing if you're going out to eat. So knowing the history is important. Again, these patients don't endorse a history usually of things like the itching that you get with allergies. And I told you, itching is a hallmark feature of things that are allergic. All right, just a word about rhinitis medicamentosa. What you see is a rebound congestion after using topical decongestants. So after using, phenylephrine or other nasal decongestants for an extended period of time, again, you may see a rebound congestion. Has to do with depletion of norepinephrine from your nerve endings. All right, so I usually never prescribe any topical decongestants unless I know that that patient is going to be super compliant and not use it for more than 3 to 5 days at the most, because they will start to get this problem, and it can be difficult to get them off of it because they use it and it helps them so much and then they want to keep using it. So probably just don't use it in the first place is the best bet. And patients don't often tell us what they're using over the counter, right? So you can get this over the counter, and so unless you specifically ask, they may not be telling you this.